Welcome to another edition of Straight Talk with Tracey. Thank you for joining me. We have a really important show today talking about the opiate addiction prevention. And I'm joined today by two guests. One is Ellen Brzozowski, who is the Director of Community Outreach at Silver Hill Hospital, and also Kira Townsend, who is a prevention coordinator for AmeriCorps and also a Silver Hill Hospital alum. So welcome to both of you, and thank you for joining me.
Thanks.
We have a lot to talk about, so we're going to dive right in. Ellen, you are going to give us a lot of information about opiate addiction, the epidemic. We're going to start with some statistics about what's happening in the country. This is a big topic.
Yeah.
It's getting a lot of press, so tell us about how big the problem is these days.
Yeah, unfortunately it just keeps getting bigger, which is horrible. But what we're seeing is the amount of opiate deaths, overdose deaths from opioids is around 54,000 across the country. That was in 2015. We don't have more current stats than that yet, but about 63% of those involved an opiate. So there was at least some involvement of an opiate, if not the only thing, in those 54 deaths.
Is there a particular age range or a demographic that's getting hit? I mean, we were talking earlier before taping started that this is happening in Fairfield County, where we all live. It's happening in the cities. It's happening everywhere. Is there a particular age group that's being affected by this?
It's across age groups, but I would say more between the 20 to 40-year-old range. We're seeing it the most. Mostly Caucasian, non-Hispanic in origin, background, ethnicity. And we're seeing it across all socioeconomic groups, so it's not really pertained to one specific population.
Right, so this is a different type of overdose epidemic than I think people imagine it to be, right? So this is hitting Caucasians across demographics. This is hitting all socioeconomic groups, right? This is hitting males and females. So this is a new epidemic that we're dealing with.
Yeah, we see it more in males, but females are definitely on the rise, unfortunately.
Right. So when we talk about opiates, explain what an opiate is, because I think it's a much broader group of medications and street drugs than we know.
Right. So it encompasses both illicit drugs and prescription medications. The prescription medications are really for pain management. So things like Percocet, oxycodone, morphine, things like that you would hear about, fentanyl used in the hospitals. But the alarming thing is fentanyl is now also being seen on the street. And the illicit drugs include heroin. And so fentanyl now is being laced into the heroin that is being bought on the street, and it can be produced illegally, and people don't know that that's what they're getting. And fentanyl is 50 times stronger than heroin. Wow. So it's really been involved in most of the recent deaths that we've seen. There's usually fentanyl involvement there. So.
And often, my understanding is an opiate addiction might start with a prescription medication. And then when those become, when somebody is unable to get those because their prescription runs out, they would then move to the street.
Right.
When those pills are too expensive, they will move to heroin, which is relatively inexpensive and easy to get.
Yes. So what can happen is someone may get injured and or have surgery and get prescribed an opiate. And then what happens is they may no longer need it, or the doctor doesn't prescribe it anymore, but they are physically addicted to it. And they need it in order to not feel sick, physically sick, like the flu and anxiety and horrible withdrawal symptoms they get from not having it. So they will go to any means at that point to secure it. So they may try to buy it on the street, and on the street a pill could be $80 for one pill.
Wow.
Whereas the same dose of heroin that you could take to get the same effect is about $5 or $6. So you can see that availability and cost is really going to drive that. Although, I think there's a perception that most people who are prescribed get addicted, and that's really not the case. We see that, maybe around 40% of people who are prescribed. No, I'm sorry, that's wrong. So there are about 40% of people will get their medication from a friend or a family member, and they will either give it to them for free or they will steal it out of their medicine cabinet. Only about 30% of the people we see that are physically addicted to these opiates are getting them from a doctor. So it's not as much, I think, as people think, although it's definitely part of the problem, but it's because of the amount of these opiates that are
being
prescribed
prescribed,
that they're available now. So they're in people's medicine cabinets and in their homes, so people have access to them.
Right.
And that's the key issue, that people may be coming in to their home to do some construction work, and they find pills missing maybe after the fact, or they don't even realize that the pills are missing. Or babysitter comes over, or your friend's friends, or people, realtors have told us that people come in pairs to open houses, and one person is talking to the realtor, the other person goes up to the bathroom to look in the medicine cabinet. So we're going to talk about prevention in a little while. But,
things we can do to...
and that's one of the major things, is getting those meds out of the house or locking them up.
Right. I've heard recently that there are some restrictions now being put on doctors for prescribing. Is some of the prevention starting there? Yes,
it definitely is. We have laws now that say that first-time opiate users, or they're getting prescribed the opiates, can only get a 7-day supply. It used to be people were walking out with a 30-day supply.
Right.
Even if you're just getting your wisdom teeth,
right,
you were getting a 30-day supply, which you don't need, you know. So now it's a 7-day supply, and recently in 2017 they passed a law that said anyone under the age of 18 can only get a 5-day supply. So, and then they have to go back to the doctor to get more.
That's great.
Because physical dependence can occur with taking opiates regularly for 4 to 7 days.
4 to 7 days.
It's a very short period of time that somebody could get physically dependent. It doesn't mean addicted.
Right.
It just means that they wouldn't feel very good if they stopped taking them abruptly.
I see.
Yeah.
Okay. Wow, that's shocking.
Yeah.
4 to 7 days.
Yeah. So that's why they limit the prescriptions now.
Right. So let's talk about what we mean specifically when we're talking about overdose, right? So from taking medication not as prescribed potentially to the illicit street drug overdose.
Right. So what happens with opiates is they stop the automatic drive to breathe. So a person stops breathing, and that's how they overdose from opiate addiction. So what happens is you might see somebody really have very shallow breath or not breathing at all, blue around their fingertips, their mouth because of lack of oxygen. Pinpoint pupils is a hallmark of opiate overdose. Also, some people get what they call a death rattle, has been called a death rattle, which is like a gurgling or snoring sound. So, and they're not usually conscious, they're not responsive.
Okay.
When you call their name or try to rouse them.
So the way an opiate works on the brain is it blocks certain pain receptors.
Yes.
So that's does an opiate that's prescribed as medication give a euphoric effect or simply block the pain?
It's usually just blocking the pain.
Okay.
And then what's happening is because the body gets used to it and dependent on it, when someone stops, they feel horrible.
They feel worse.
They feel worse. They, if this is baseline, they go below baseline. So they have to take the medication just to feel like they can function,
right,
to feel better. So, so that's really what happens with people who are prescribed them for a medical reason. And that's why they have to continue to be on them under a doctor's supervision until they can find other ways to detox them off of it and then manage their pain.
Manage the pain, right.
Because opiates were never designed for chronic pain, really. They were really prescribed for end-of-life cancer pain or acute, after surgery, that kind of thing, very short.
Never meant for long-term use, yeah. So, then the brain will seek more and more and more. So what might have been one, say, 5 milligram dose would have done the trick. They are going to need more and more and more to get the same feeling of...
Yes. And it's been shown now in studies that for people who are in chronic pain, once they come off the opiate, their pain actually gets better. Because over time, it actually makes the pain worse. So, if someone's on it for months or years or things like that, they're finding that really 3 months is sort of the max that somebody should be on an opiate for chronic pain.
Right.
So, yeah.
So you can see how easily somebody is going to become, number one, that 4 to 7 day period to get physically addicted or physically dependent.
Right.
And then the addiction shortly after that.
Right, it can take off from there.
Because it becomes that I can't live without it. So it's a
Yes.
psychological as well as a physical.
As a physical, yes.
Yeah.
And the physical is very real. I mean, it's a very uncomfortable place to be. You know, it's like the worst flu you've ever had coupled with the worst anxiety you've ever felt. So people feel like they're crawling out of their skin. So they'll do anything to not feel that way.
Right,
You know?
right.
And it is a disease. It takes over the brain. It
That's
hijacks
right.
the brain.
That's
so.
right, yeah. So we have a new medication called Narcan, which has been a revolution in the
Yes.
way that we are dealing with the opiate epidemic. So talk a little bit about when Narcan was developed.
Well, Narcan has been around for years and years and years. They've used it in hospitals. But in 1996, they started Narcan distribution programs to sort of deal with this epidemic that was emerging in the 90s. Because in the 90s, that's when these new medications, such as oxycodone, were produced. And they were really marketed as great for chronic pain and as non-addictive. So it was not, the information was not correct when the doctors were given this new medication. So, so around that time, people started developing addictions, and then unfortunately overdose became more prevalent. So Narcan will reverse an opiate overdose if given in time. So you have about a 1 to 3 hour window period after an overdose to give the Narcan to have it be effective and possibly reverse the overdose. You may need more than one dose of it. It comes, this is just an example, it comes 2-pack, 2-dose in here, because you sometimes will need to give a second dose in order to revive somebody from, but it replaces the opiate in the receptor site in the brain. That's what Narcan does. And so people then begin to breathe again while the Narcan lasts.
Right.
But Narcan only lasts about 30 to 90 minutes. So someone has to get medical attention. They can't just be revived from Narcan and go about their business.
Right, you're
and
not going to
say,
go to
oh,
work.
I'm okay.
Yeah.
No, you have to go to the hospital. You have to be monitored to make sure you don't re-overdose, because the opiate is still in their system.
Right.
And when the Narcan wears off, they could overdose again. So we always tell people before you even administer the Narcan, you're going to call 911
And
to
get
get
that.
help on the way, so that you have backup and
Right.
the person's being monitored.
Right.
Yeah.
So it buys you the time to get to the hospital, to get the medical attention that is life-saving.
Yes.
Right.
Yes. Yes.
So let's talk a little bit about the different ways you can get the Narcan, and then you're going to demonstrate
Yes.
how to actually
Sure.
administer the Narcan.
Yes.
So who should have Narcan available to them, and how would someone get it?
Okay. So anybody who's on an opiate, even if it's a prescribed substance, should have Narcan with them, and their family members and friends should have it available to them, because you can't self-administer Narcan. You're not conscious, so someone has to do it for you.
Okay.
So that's number one. So really anybody. It could be somebody who is addicted to heroin. They should also have Narcan available to them, and their friends and family should also have the Narcan available. So it could be someone who's prescribed medication or somebody who's using illicit drugs.
Okay.
So anybody in that arena should have the Narcan. So now there are Narcan distribution programs, like Silver Hill will go out and do community education and then distribute Narcan. And we give out this one. This is the nasal spray that we give out. It looks like this. And then there's also pharmacists that are now certified and are able to prescribe and dispense Narcan right from the pharmacy. So there's a couple of different places you can find out, where most pharmacists, like at CVS and Walgreens and places like that, are certified, but you should always check before you go. And so say a mother was concerned about her son or daughter, knew that they were using heroin, for instance, and wanted to have Narcan in the house. They could go to a pharmacy that participates in this program, say to the pharmacist, I'd like to get a prescription, or I'd like to get a Narcan kit. The pharmacist would do some education with them, because you can never just give it out. You need to
Right.
provide some basic education, and then they could get the Narcan that way. There's an app that people can download on their smartphone called Narcan Now, and then you can just put your zip code in it, and it'll give you all the pharmacies around your area that have Narcan available. There's also DMIS, which is the Department of Mental Health and Addiction Services, has a website in the state of Connecticut that has a whole list of pharmacies that participate in this program as well. And again, you put in your zip code and they give you pharmacies in your area that will prescribe. you know, insurance, co-pays, deductibles, all those things relate if you're going to get it at a pharmacy. But I think now it's become very available, and the co-pays are really very reasonable.
Right.
And things like state insurance, Husky or Medicaid, I think there's no co-pay for those kinds of things. So.
And is there a limit on the number of times you can use Narcan before it becomes either doesn't work or is dangerous? So, for instance, I would imagine that there's some backlash in saying, well, just keep the Narcan around and you can continue to use the heroin. We're going to talk about prevention, obviously, but is there, does it have, does it stop working, or how many times can you use it?
So each kit contains 2 doses. So, you know, at a single time, I've heard though of EMS giving up to 6 doses for a single instance to try to get somebody back, probably because there was fentanyl on board there. It does take longer when there's fentanyl involved. So, you know, but that's something that EMS would do, or a medical professional. You know, for a lay person in the community who's trying to administer it, I'd say you give them 2 doses, and you know, hopefully by that time EMS is already there, so you're out of that picture. But that's really about it. Narcan itself is not harmful. You know, so if someone's not having an opiate overdose and you administer the Narcan, it's not going to do any damage to them. A lot of people have concerns about that too. Am I going to hurt somebody? You know, if
similar
I give them
to an
this,
EpiPen if someone's having an anaphylactic reaction. Okay.
So if someone's unsure whether it's an opiate overdose, I always say you just
or on the side of doing
just
it.
give the Narcan. It's not going to do. It's not addictive. It doesn't have any street value. It's, you know, none of those things are
purely
a concern.
preventative.
Yes. Yeah. I mean, there are some people that there's been reports are allergic to Narcan, but you don't really know that until you administer it. And if someone is dying or dead, you know, you want to do everything you possibly can. And then again, EMS is on their way. They'll deal with whatever complications may occur, but very rarely reported any complications from administering Narcan.
So if you give it, let's say 1 week, and you have another overdose the next week, does it have the same effect?
Yes. Yes. It doesn't wear off, or the effectiveness isn't less because you've given it the week before.
Okay.
No.
Interesting.
Yeah, it works the same way.
Okay. Why don't we take a quick break? You're going to give us a demonstration of how easy it is to use these medications, and then we're going to talk about preventing.
Great. Okay, thanks.
We'll be right back.
For 1 in 4 Americans, mental illness hits close to home. And since 1931, Silver Hill Hospital has also been close to home. For individuals and families facing the challenges of mental illness, Silver Hill offers a highly trained, compassionate staff that provides state-of-the-art care in a beautiful and private setting. If mental health issues hit close to home, remember, there's a world-class psychiatric hospital right in the neighborhood.
Welcome back. I am joined today by Ellen Brzozowski, who is the Director of Community Outreach at Silver Hill Hospital, and Kira Townsend, who is a member of AmeriCorps, and we'll be talking about her efforts on opiate prevention. So, thank you both again for being with me. We are going to now see a demonstration of how the Narcan works.
Right. Okay. So there's 4 different ways you can administer. 2 are intranasal and 2 are intramuscular. So I'm going to show you one of each.
Okay.
The other 2 are sort of older methods that you have to put together and draw up the meds, and probably most people are not going to get those 2. They're going to get either one of these. So the first one, this is the one that we give out when we go out into the community. It's an intranasal. It's all put together. You don't really have to think about it. It almost looks like an allergy spray.
Yes.
So you just put your forefinger and your middle finger around the nozzle. Your thumb goes on the plunger underneath. Person should be lying down on their back, and you should support their neck as you're going to do this, and just tilt their chin up a bit so that none of the liquid leaks out. It's a mist when it goes into their nose.
Okay.
So you just choose one nostril, you put it in as far as you can, and then you depress the plunger all the way so that the full amount of the medication goes into one nostril.
Okay.
If you were to need to give a second dose after about 2 to 5 minutes, if the person doesn't respond, you'd give a second dose. You just choose the other nostril and do the same.
What would someone expect as a response? Would they jerk awake, or would they slowly start to, so that you're aware?
You're aware, yeah. It's different in different situations. Very small amount of the time we've heard that people are sort of more alert and awake right away and almost can be combative because they're feeling so sick, but that's very rare amount of the time. Most of the time it's sort of a slow, groggy response, and people kind of try to sit up, and you just have to support them through that. Sometimes they'll start breathing, they're still lying down, and you want to put them in what we call the rescue position, which is on one side. So that if they do vomit, because that can be a side effect, that they need to, they don't want to choke on their vomit if they're laying prone on their back.
Right, good to know.
Yeah, so that's what you would feel. And people will be in withdrawal. If they are opiate dependent, they will wake up feeling sick, not feeling comfortable, and hopefully at that point 911 is there and they're taking care of that and they're helping them through that. But you just don't want them to walk away or to use again, because you don't want them to re-overdose.
Right,
so
yeah.
Those are the important parts.
Very important to call 911 as soon as this whole process.
Before you even open the box, you have to call 911. Yeah, and give them as much information as possible. They're in the kitchen, they're in the downstairs bathroom, so they don't waste time trying to find them.
So there's the intranasal, and then
this is the intramuscular. It's called EBZIO. Very, very easy to use, probably the easiest of all of them. So this is a trainer, but it'll demonstrate, it talks to you. All right, so when you pull up, it begins to talk, and it will tell you there's no drug.
Place black end against outer thigh, then 5, 4.
So it's very simple.
Wow.
2, 1. Injection complete.
So you don't have to think about it. You don't have to remember what to do. It will. Thank you. So it's
very polite.
It's very polite. But it's, people like that because
you're
when
panicked.
your adrenaline's going, you can't think straight. And this one too, I mean, there's really nothing to do except take it out and plunge it into the person's nostril. So they're both very effective and easy to use.
So do the packages come? They come with two.
So they look like this when they're in the packages.
Do they come with a trainer?
This one comes with a trainer.
Yeah.
This does not. It just comes with the 2 doses.
Yeah.
So someone could practice on this.
Yeah.
One.
We have an EpiPen at our house for my son, and we were always taught to either when they expire or to use the training, because when you're in that panic moment, all of the education you might have had about it goes out the window.
Goes out the window. Absolutely. Yeah.
Great. So the intranasal and the intramuscular. That's great.
Yes.
That's fantastic. So let's talk a little bit, Kira, I want to get you in the conversation here and talk a little bit about what brought you to this field, your own personal experience, and together what you guys are doing to help with prevention.
Great. Well, I should say I do want to share as well that I do have a loved one that Narcan actually brought back to life.
Wow.
And that is just goes to show you how life-saving it is and how important it is to, educate the community in getting Narcan trained and passing it out to as many people as we can, because you never know.
Right.
And it's always better to be equipped with something that could be life-saving.
Right. Now, can I ask, was that administered by a family member?
By EMS.
By EMS,
yes.
okay.
This was a few years ago, yeah.
So
when it was just coming on the market.
When you're out talking about prevention and talking about this amazing, as you say, life-saving medication, do you ever get the feedback that people shouldn't have this as an option because they should stop their opiate addiction rather than having this as a, let's say, a crutch? Because there is that stigma. If I have Narcan in my house, it acknowledges that someone in my family, a loved one, has a life-threatening addiction.
Right, and I'm grateful that we have not faced any of that. However, there is that belief out there and that stigma out there, and to that I would say, it's similar to someone having heart disease, and would you not allow them to have access to a defibrillator in case they have a heart attack or something like that? So it's always better to err on the side of caution, and stigma is a piece in addiction, unfortunately. But the more we address it as a disease, which is what it is, I think the better people will understand and come around with compassion, and the quicker we will be able to find solutions to these problems.
Right.
Just if I could just jump in, the other thing I always say too, because I do get that sometimes in the community when I'm doing the Narcan presentations, people will bring that up or ask me, and I'll say, we can't get people into treatment if they're no longer with us, if they're
Right.
dead. So Narcan gives us an opportunity. It's just another opportunity to get somebody counseling and possibly into treatment for their drug addiction.
Right,
So,
right. And Kira, I think the face of addiction is changing. And so talk about what brought you to this field and then what you're doing with AmeriCorps.
Well, definitely. So I am a person in recovery myself from alcohol use disorder and substance use disorder. And I am someone that is very grateful for that I did get another chance at life. I feel very lucky. It takes a lot of work. It's a one day at a time type of thing. And so treatment and recovery is possible. Hope is possible. And it took me a while to get there, but March 1st, hopefully, I will have 4 years in long-term recovery. So coming up on that, and being personally affected myself, not only that, but I have lost friends, dear friends, to opioid overdoses, and people in our community are dying, and this hits home for me, and it's a really important issue, not only to me, but for our community. And I believe that we must have things in place for preventative efforts and raising awareness, education, because in order to take action, we have to be aware that there's a problem,
Right.
and we have to acknowledge that there is something that we can do about it, but we have to work together.
Right.
So part of that is why Ellen presented this job opportunity, service opportunity for me to work with AmeriCorps and Prevention Corps, CT, and it has been such a phenomenal experience, and I will be working over the next few months as well, helping to raise awareness and doing educational forums, Narcan trainings with Ellen, and bringing our community together to really work on addressing this issue that is so prevalent and so important, but there is still a stigma to it.
Yeah.
So addressing that, being a face of someone that can say, you know, I am someone that lives with addiction, I live with substance use disorder, and I am managing it. It is treatable. But there has to be this level of shame that you don't have access to anymore. Shame is not something that will help people get into treatment.
Right.
It's something that will prevent from treatment.
That's right.
And so yeah.
So this is a service opportunity do you have a particular area that you work in?
Yes, I am working in New Canaan specifically, along with the support of Silver Hill and the New Canaan Community Foundation. But we are focused, the Prevention Corps is focused in southeastern Connecticut and, southwest Connecticut. And,
I always get this.
yes, and so that is our main focus around Fairfield County and surrounding counties. But we are definitely this group of people that are trying our best to kind of be on the front lines and work to raise awareness.
Yeah, it's amazing. And is AmeriCorps nationwide? Is that something that
AmeriCorps is
people can look in
nationwide.
their areas to see if there are people like you that can help and come and educate?
Absolutely, absolutely. So check AmeriCorps.com or AmeriCorps.org. And there are many, many different organizations that are supported by AmeriCorps members and
Right.
vice versa. American Red Cross, there's Habitat for Humanity. It's a broad range of service and volunteer, and it's a great community and a great thing to be part of.
Yeah, that's great. So what are some things that we need to get out there in order to educate people about prevention? So number one is education, right?
Right,
So
just awareness.
not from your family to your community to our country, we need to take our head out of the sand and say that this is an epidemic and we can't keep letting our young people die.
Right.
So that's kind of my soapbox. What would you guys say that, how can we help people to prevent opiate addiction and certainly overdose?
I think when people go to a doctor and get a prescription, any kind of prescription, really asking questions. Because there are even some providers that are not fully up to speed on
Yeah.
some of these medications and what they can and can't do, and what the first line would be for pain and that kind of thing. So really asking questions, asking, is there an addictive potential to this drug? And there was a law passed just this year, beginning of 2018, saying that now when a prescriber prescribes an opiate, they have to talk about that potential. So, but we need to be educated consumers and really just ask questions, and don't just assume because a doctor's giving you a medication it's fine.
Right, and ask for alternatives. Are there alternatives to manage this?
And people can also say, they can have written in their medical chart, I don't want an opiate prescribed, especially people who may have a substance use disorder, have a history in their family even, they can elect to not have that.
Right.
So, and then there's going back to not having these prescriptions in your home, like if you've had old ones, getting them out. Many police stations have a 24-hour, 7-day-a-week drop box in their lobby. You can go and drop off unused, unwanted medication. Nobody has to know you're doing it.
Right.
They also do a drug take-back day twice a year, October and April. The DEA sponsors it through the police, and you can just drive through the police parking lot and drop off meds. So that's another way to do it. If people do need to have their medication in their house, to lock it up so that people can't get access. The other thing that we that is relatively new is something called Deterra, which is a medication disposal bag, so that people don't have to go anywhere. They can do this in their own home, and many pharmacies have these now. And in the state of Connecticut, every pharmacy, or all CVSs, I believe, have gotten these from the state, and one per family is free.
Wow.
So you can go in and request, just say the purple medication disposal bag.
Right.
And it gives you very specific instructions on the back. Up to 45 pills, 6 ounces of liquid, or 6 patches can be put in one of these bags. So you put the medication in, you fill it halfway up with warm water, there's a little Ziploc up top, you zip it up, you agitate it, it inactivates the medication, so you throw it away in the garbage.
Wow.
And you don't have to worry about contaminating the water supply, because people shouldn't flush their medication.
That's a good point.
Yeah.
No medication should go into the.
Please do not flush your medication.
Don't flush your medication. Right. Yeah. Even in the heat of the moment. Right. Yeah.
And people say, well, can I just throw it away? Well, again, if you're dealing with somebody who has an addiction, they would go through the garbage. It is a disease. People will go to any lengths to get their hands on medication. So something like this, even if they got to the medication, it wouldn't have any effect.
Right.
We also tell people they can put it in coffee grounds or cat litter, things like that, if they wanted to dispose of it at home.
Right.
But those are the kind of messages that Cura is going to be going out there and telling people about.
Yes, definitely empowering the community with education, with these resources. We have a local drop box in New Canaan at the New Canaan Police Department that anyone can go and put their meds, no questions asked. Because so often we are seeing people that are overprescribed, and may not be taking those medications, but they're in the houses, they're in, places that aren't locked up, and those are ways that, some people can dip into getting addicted.
Absolutely, yeah. We can't assume it will not happen to us.
Right.
Even if we're not using them, if they're in our home, we have a responsibility to manage that safely.
Right. And one of the other class of medications that's also very highly prescribed, especially in Fairfield County, is benzodiazepines, which are like Valium, Xanax, anti-anxiety or sleep medication aids. And those are also highly addictive.
Yes.
And I know we're concentrating on the opioids, but many times what we're finding is people who die of an opioid overdose, they have benzodiazepines in their system as well, and the combination is deadly. So as to your point, any kind of medication really should be locked up.
Right. We have a responsibility.
Right.
Any final words before we have to leave? And we're going to provide resources at the end of the show so people can tap into all these great resources that you guys have provided. But if one word of wisdom before we head out?
I would just say reach out, get help, try not to get into that shame that Cura. So it is a disease, there is help, there's hope, and so please reach out.
Yeah, and Cura?
Absolutely. I second everything Ellen said, and definitely compassion. Just understand this is a disease, and our community is trying to do everything that we can, and it takes a village. So everyone has a part to play.
That's great. Thank you both so much. This is a really important topic, and can't thank you enough for all that you're doing for our local community and hopefully communities across the country.
Thank you,
Thank
Tracy.
you.
Thanks so much.
We'll see you again next month on Straight Talk with Tracey. Thank you so much for joining me today.